Welcome to Roadmap to Residency. Hello everyone, I am Abhiraj. Welcome to our club to 50 matchmaker sessions. Here we have a question with us. So which of the following conditions is most likely contributing to the observed male infertility? A 34-year-old man and his partner are seeking medical advice due to difficulty conceiving after a year of regular unprotected intercourse. This man has no significant medical history and a physical examination reveals normal secondary sexual characteristics. Semen analysis shows a decreased sperm count, reduced sperm motility, and an elevated percentage of morphologically abnormal sperm. Which of the following conditions is most likely contributing to the observed male infertility? Varicocele, erectile dysfunction, hypogonadotropic hypogonadism, oligoasthenotetratozoospermia syndrome, or cryptorchidism. So, oligoasthenotetratozoospermia is a term used to describe a combination of three sperm abnormalities: decreased sperm count, which is called as oligospermia, reduced sperm motility, which is called as asthenospermia, and increased percentage of morphologically abnormal sperm, which is called as teratospermia. Now, these combined abnormalities can significantly impact the male fertility by reducing the chances of successful fertilization. OET syndrome is a common cause of male infertility, and it can result from various factors, including genetic factors, environmental factors, and infections. Now, these are the typical causes of male infertility. Let's just skim through all of them. So it can be divided into these sub classifications. So number one is the sperm production problems like chromosomal causes, undescended testes, torsion of testis, varicocele, or radiation damage. Due to the blockage of sperm transport, maybe due to an infection, prostate-related problems, or absence of vas difference, maybe due to some sexual problems like fear of ejaculation, erectile dysfunction, spinal cord injury, or prostate injury, due to hormonal problems like pituitary tumors and anabolic steroid abuse, and due to some sperm antibodies like vasectomy or injury or infection in the epididymitis. We have one more question with us. So which of the following condition is the most likely cause of the observed female infertility? Now, 29-year-old woman and her partner have been attempting to conceive for the past 18 months without success. The woman has regular menstrual cycles and her partner has normal sperm parameters. A pelvic examination reveals no abnormalities and a medical history is unremarkable. Initial investigation include a hysterosalpingogram, which shows pattern for a fallopian tube. However, subsequent evaluation reveals increased level of luteinizing hormone and follicle-stimulating hormone with normal estradiol levels. And which of the following condition is the most likely cause of the observed female infertility? PCOS, POF, endometriosis, uterine fibroids, or cervical stenosis. So premature ovarian failure is also known as the premature ovarian insufficiency. Is a condition characterized by the loss of ovarian function before the age of 40. It leads to irregular menstrual cycles, amenorrhea, and infertility. Elevated cycles of luteinizing hormone and follicle-stimulating hormone with normal estradiol levels are characteristic of POF, indicating decreased ovarian resolve and function. Now, this is the basic algorithm behind infertility. So, whenever there is failure to conceive following more than 1 year of unprotected sexual intercourse, then in 35% of cases is due to the defect in the male. If not, there are some unexplained causes in the 15% of individual, and the pathology may be in the female in half of the cases. So, there can be a pathology in the uterus, for example, fibroid polyp, Asherman syndrome, adenomyosis, or cervical stenosis, for which we need to do hysteroscopy or hysterosalpingography. There can be defect in the fallopian tube, for example, pelvic inflammatory disease, endometriosis, adhesions, or previous tubal pregnancy. For example, the defect in the ovary, it may be due to C types. For example, decreased FSH, it may be hypothalamic or hypopituitarism. So hypothalamic may be due to weight loss or exercise or excessive exercise or stress or psychosis. Or it may be due to hypothyroidism or hyperprolactinemia. In case of normal FSH, it is due to the PCOS or obesity. In case of increased FSH, it is due to the premature ovarian failure, premenopausal changes, and Turner syndrome. Now, this is the basic pathogenesis of female infertility. So let's skim on the important parts of this flow chart. So when there is extreme stress or eating disorder or excessive exercise, it decreases the GnRH from the hypothalamus. And whenever there is decreased GnRH, there is decrease in the LH and FSH production, which will ultimately decrease the ovulation of the patient. In case of polycystic ovarian syndrome, there is increased androgen production and increased estrogen earlier in the menstrual cycle. Now, this will lead to again decrease in the FSH and decrease in the follicular growth and ovulation. In case of premature ovarian failure, it increases the rate of follicle depletion, and since there are fewer follicles, there is anovulation. The damage in the germ cells that accumulates over a woman's lifetime or some age-related changes will ultimately decrease the quality of oocytes. The pelvic inflammatory diseases like chlamydia or gonorrheal pathogens, they can cause tubal occlusion. If there is any previous tubal surgery, then it can cause a scar and then it can cause tubal occlusion. If there is endometriosis, then there may be local inflammatory response further, which can decrease the egg or sperm motility. If there is some congenital malformation, example, the inability of cervix to produce mucus, or if there is any uterine pathology which does not favor the fertilization, which does not favor the implantation, then it can cause infertility. If there are some uterine fibroids which can ultimately inhibit the sperm transport, for example, in case of cervical big fibroids, then it can cause female infertility. These are some of the basic important points about the female infertility. So how you assess or how you assess a patient about the female infertility. So whenever there is a request for infertility evaluation, we need to evaluate the male and female at a same consequence time, at the same time. So for the male, we have to take the history and physical examination, and we have to go for semen analysis. For the female, if the age of the female is less than 35 years and is attempting pregnancy for more than 1 year, then we need to counsel on menstrual cycle, ovulation, and timed intercourse. We need to optimize the chronic medical conditions, and we need to do pre-conceptional counseling. If there is evidence of ovulation, then we need to evaluate the ovarian reserve. But if not, we need to obtain the serum progesterone level on day 21. Now, if it is more than 3, then again we need to evaluate the ovarian reserve. And if it's less than 3, then we have to go for further investigations like thyroid stimulating hormone, prolactin, and FSH. So the next topic is assisted reproductive techniques. Now this thing is not mentioned in your first aid, so I have combined the materials from different places in this video to make you understand the important things about the assisted reproductive techniques. So whenever there is infertility, then the patient wants to go about the assisted reproductive technique. Then these are the techniques that you can offer the patient: intrauterine insemination, artificial insemination by husband, or artificial insemination by the donor. We can go for gamete intrafallopian transfer, or we can go for in vitro fertilization, which is the most commonly method used. So indication of intrauterine insemination: whenever there is cervical factor, whenever there is chronic anovulation, whenever there is some immunological disorders or endometriosis, then we can go for intrauterine insemination. For the ovarian stimulation for the intrauterine insemination, we can medicate the patient with clomiphene citrate plus FSH, or only FSH. So the ovulation stimulation for IVF is by a short protocol of a GnRS from day 1 or FSH from day 3. We can go for a long protocol, which is a GnRS from day 20 of previous cycle to FSH of 150 to 300 from day 3. Thank you for watching. Keep studying hard.